afternoon. Great audience. I feel privileged and honored to be here to deliver a small talk on surgical nutrition. And when I went through this topic, there are a lot of calculations I have made, plus, minus, division, multiplication. I never did in my 10 years. Quite difficult one. And I'm thankful to the organizers for the invitations and giving me the opportunity. Especially Dr. Nichols and Sakia and Dr. Robin and the whole organizing team. So my talk will be on enteral and parenteral nutrition. So I come from KISS Medical College and I bring along warm wishes and the regards from my colleagues and my team. Going back to the history of surgical nutrition, the earliest evidence of the surgical nutrition dates back to 3,500 years ago with the help of enema in Egypt. And then this is the enteral feeding, and regarding the parenteral nutrition, it dates back to 1600, where they used the feather quill with the pig blood for the purpose of the intravenous nutrition, using milk, sugar, egg white. The modern era of the enteral nutrition was started by John Hunter, where he used milk, sugar, wine jelly via the whalebone covered with tail skin. And in late 80s, the President Garfield was assassinated and he was put into the enteral feeding through the enema using whiskey, the beef broth, and it continued up to 79 days. So, objective of my presentation today is the indications of the nutritional support, the determination of the nutritional status, the effectiveness of nutritional support in well-nourished versus malnourished patients, route of nutrition enteral versus parenteral, and the appropriate amount and composition of diets. So, regarding when you start the therapeutic intervention, there are 3 criteria that must be satisfied. When you think of any treatment, is this treatment justifiable with no treatment? Second is, if you are using the treatment, then is the benefit outweighs the risk? Third is, when you use the treatment, is it the best form of the treatment? So these 3 criteria must be followed. And regarding the nutritional status regarding the providing the nutrition, so we have to follow these 3 things as well, because when you think about the parenteral nutrition over the enteral nutrition or vice versa, there are complications, there are benefits, there are certain indications, so you have to take all these things into account. So look at these 2 clinical pictures. This young patient had undergone the appendectomy and later on presented with the wound infection and later it followed with the intestinal fistula. And this recently done the exploratory laparotomy, we had to remove this segment of the small bowel. So how do you consider regarding the providing the nutritional supplement for this patient? So So the first issue is, who are the patients that needs nutritional support? So in general, the patients who are nutritionally depleted, the patient who are unable to take nutrients by GI tract, and those who should not take nutrients by GI tract because of inherent risks or complicate the management of their current surgical disease. So regarding the few indications for the nutritional support that needs to be considered are severely malnutrited patient, the patient who had undergone surgery, the outcome is short bowel syndrome, the patient not expected to feed in 7 days, prolonged ileus or intestinal obstruction, intercutaneous fistulas, pancreatitis, the major bowel surgery needing esophagectomy, Whipple surgery, or total gastrectomy, or even the resection of the colon. The second issue is the determination of the nutritional status of the patient. So how do you assess the nutritional assessment of the patient? There are so many studies that say that there is no single gold standard method of assessing the nutritional status of the patient. However, there are a few markers of assessment of the nutritional status: weight loss, subjective global assessment, transport proteins like albumin, transferrin, thyroxine binding pre-albumin, retinol binding protein, immune incompetence system affected by total lymphocyte count, delayed hypersensitivity, prognostic, nutritional index, and in acute conditions there is prognostic inflammatory nutritional index. So to start with, the unintentional weight loss is one of the markers of nutritional assessment. And there is an equation: the usual weight minus the present weight divided by the usual weight into 100 gives you the percentage of the weight loss. And the malnutrition is categorized as mild, moderate, and severe regarding the weight loss the patient has observed. If it's less than 10%, it's mild over 1 month period, 10 to 20%, moderate over 6 months period, and if it's more than 20%, it's severe in 6 months period. And more than 30%, they are pre-morbid, and more than 50%, they are nearly at the phase of pre-mortality. The subjective global assessment, this is nothing but the clinical history and the clinical examination. Maybe the different institutions, they have their own system of subjective global assessment. So usually they follow the anthropometric, the triceps, skin fold thickness, median arm circumference, muscle mass, and then creatine height index, which is the 24 hours level of creatine in the urine over the height, and muscle strength. This relates to the grip and the function. The muscle strength, it correlates well with the complication rate post-operatively. But the outcome of these, the markers, is still the subject of debate regarding the outcome of the disease. Among the biochemical markers, the albumin is considered to be the best marker, but there has to be some the controversies even regarding the albumin, because there are some disease factors like Marimus where you find the level of the albumin quite high because of some physiological changes. And there is transferrin, and there is thyroxine binding albumin, and the retinal binding protein as well. There is one equation, you call it Prognostic Nutritional Index. So this is the equation. The higher the index, there is increase in the risk of the complications post-operative period. So it is directly proportional to the outcome of the surgery post-op. And in acute conditions, there is prognostic inflammatory nutritional index. So these are the markers of nutritional status of the patient. Now, regarding the method of the nutritional status and nutritional supplement, then there are certain things that you need to consider. One is the GI tract is functioning or not, and is the condition is severe enough that the patient needs sophisticated and specialized nutrition. When the patient's GI tract is patent, then you can go for the enteral feeding, which is the natural one, and natural is always the best. And in natural one, there is short-term and there is long-term method of providing nutrition. In short-term, then there is nasogastric tube, and in long-term, you can go with the gastrostomy, or you can go for the jejunal, or maybe you can go for the endoscopic gastrojejunostomy or gastrostomy. So in the meantime, the third factor that plays a role is the effectiveness of nutritional support. So when you consider for the nutritional support to the well-nourished, to the malnourished, and to the severely malnourished patient, there is a lot of difference. But many studies say that there is no significant impact regarding the nutritional supplementation in well-nourished patients. But in severely malnourished people, there is 30% reduction in the post-operative complications. In moderately malnourished people, if we start the enteral feeding, and if it's supplemented by arginine, RNA or omega-3 fatty acids, there is good outcome after surgery. But there is some dilemma. If given early in general surgical patients, if given early, the complication increased by 10% from 30 to 40. However, the preferred nutritional support has to be started within 5 to 10 days of the surgery. So these are the roots of the enteral and parenteral nutrition that we are talking about. So the first thing I again re-emphasize is the GI tract functional state. So if yes, then you obviously have to go straight to the enteral route, which is natural, and there are a lot of benefit associated with the enteral feeding. The short term you can use the antitube. I don't need to explain about this. And long term there's gastrostomy and the jejunostomy. And parenteral route, again, there is central and there is the peripheral one. So in peripheral, we use for the short term, and in parenteral and central, we can use it for the longer period of time. So regarding the enteral versus parenteral nutrition, there are so many studies done. One of the studies considering the blunt and penetrating abdominal trauma, they said that the early enteral feeding is associated with good outcome and less complications. And it all depends upon the severity of the disease itself. If the severity of the disease is increased, then the earlier the enteral feeding, the less is the complications. So regarding few studies done for the head injuries, severe head injuries, I found 3 studies comparing the enteral with parenteral feeding. 5 of the studies found no benefit regarding the enteral feeding. But one study found the benefit regarding the enteral feeding. Maybe that's why I just want to remind you that it all depends upon the disease pattern itself. There are a few studies putting comparing the enteral over the parenteral. The enteral feeding is always better in laparotomy, ulcerative colitis, even in liver transplantation and acute pancreatitis. Because the enteral feeding is more physiological, it has got less cardiac work, safer and more efficient, better tolerated by the patient, and it's more economical. So you have the enteral access through NG-tube, gastrostomy, jejunostomy, and percutaneous endoscopy gastrostomy, and the transgastric jejunostomy. So there are different compositions, the method you can use through the nasoenteric tube feeding, which consisted of the blended food and the whole protein formulas. So there are stents and Glassman and percutaneous endoscopic gastrostomy. And you can even go for the jejunostomy, which is nothing but the having the access, which is the natural. The precautions to be observed to prevent reflux and aspiration is that the patient has to be kept in 30-degree angle. Patient should be conscious and stop the feeding at 11 o'clock. Use 10 French catheter, and after administration of the food, clean the tube. Prolonged use render the cardiac incompetent, and sometimes it causes the stricture. So there are a few differences between the gastric feeding and jejunal feeding, but in both it is always preferable to use the isotonic solution. And the rate of infusion is 25 to 30 ml per hour. The increment is 25 to 30 ml per hour daily, and it may be associated with some kind of vomiting in gastric feeding and distension, diarrhea, colic reflux to NG-tube in jejunal feeding as well. So complications, the enteral feedings are not without complications too. The malposition of the catheter, the aspiration, the overloading, and perforations, which is rare. There are, of course, the metabolic complications as well, leading to hypoglycemia, hypophosphatemia, so all these electrolyte imbalances, and refeeding syndrome, which is because of the intracellular mobilization of potassium and the phosphate, and small bowel necrosis and pneumatosis intestinals. Regarding parenteral nutrition, the principal indications found in seriously ill patients suffering from the malnutrition, sepsis, severe surgical or accidental trauma, where the use of gastrointestinal tract feeding is not possible, but can be supplemented in patients with the inadequate oral intake. Nutritional support can be achieved, but the alteration in the disease process have not been established. There are few indications: newborn GI abnormalities like gastroschisis, omphalocele, alimentary tract obstruction like achalasia cardiac, achalasia stricture, carcinoma, pulmonary obstruction, prolonged IBS, prolonged respiratory support, and large losses. There are proven efficacies in radiation leukemia-enteritis, hypermesis gravidarum, the efficacy was established in pre-op, cardiac ataxia, pancreatitis, patient in ventilator support, and prolonged IBS. There are a few contraindications regarding the total parenteral nutrition, lack of specific goal for the severe metabolic management, cardiovascular instability, feasible feeding the patient with good nutritional status, infants less than 3 cm small bowel, and irreversible decerebrate conditions. So we have the peripheral and central TPN. So in peripheral, you use 3% of amino acids along with dextrose, but in central, you can use 50 to 25% of dextrose, maybe because it is less irritant to the large lines. So there is few fundamental difference between the central and the peripheral. The daily calories you can provide through the central line is 2,000 to 3,000, in peripheral 1,000 to 500. Duration of therapy through the central line can be done in more than 7 days, whereas in peripheral line, so usually we keep it for 5 to 7 days. And there are a few this nutrients substrate profile differences. So while you do the TPN, make sure that you monitor the vital signs, blood sugar, the weight, maybe in 2 days, and electrolytes and this total protein levels as well. So there are a few basic composition of formulations, which is not the matter of my discussion today. And carbohydrate, amino acids, lipid emulsions, and vitamin stress elements and electrolytes. Even the parenteral nutrition has got some complications, which is related with the technique or maybe related with the metabolic changes and the sepsis. The last but not the least is that you need to have the proper amount and composition of diet. The basic need is 25 to 30 kilocalories per day, and which should consist of 30% of the fat and 1 gram protein per kg per day. And even in a stress condition, the requirement is 35 kilocalories per kg per day, and it depends upon different disease conditions as well. So these are the energy and protein need for surgical patients in normal to moderate in hypermetabolic stress and inborn patients. Regarding the body weight, the malnourished and well-nourished, the actual body weight can be calculated, but for the obese, there is concern about the overnutrition. That's why the body weight has to be adjusted, which is the ideal weight plus 0.25 multiplied by actual weight minus ideal weight. And for significant fluid overload, the estimated body weight is all we need. So this is the calorie requirement for the protein, glucose, and fat. So in summary, I want to re-emphasize is that before we embark on the nutritional support for the patient, we have to think what is the indication for this patient for the specialized or the general nutritional support. While you consider for the nutritional supplement, how do you assess the nutritional status of the patient, the effectiveness of the nutritional support you use, route of the nutrition, and finally the appropriate amount and composition of diet. Thank you very much.